So, good morning. So let's begin our lecture today. So today's topic is about colon, rectum, and anus. And we will talk about four topics. The first is anatomy, physiology of the colon and the rectum. The second is inflammatory bowel disease. There are two kinds of disease. One is UC, ulcerative colitis, and in the CD, Crohn's disease. And the third one is colorectal neoplasia. There are two types of different diseases. Is polyps and the cancer. So this one is the we should pay more attention. It's the most important part is here. And if we have some spare time, maybe we will talk up something about the anus disease, rectal prolapse, hemorrhoids, and the fissure and the fistula. This kind of disease is very popular. It's very popular in the human, but it's less important in this topic. So if we have time, we will talk about something. Okay. So just go through it for the anatomy of colorectum. So different parts: ascending colon here, and transverse colon, descending colon, sigmoid colon, and this is rectum. And at the end is anus. So the colon and rectum is a tube of variable diameter, about 150 centimeters in length. So we have learned a lot in the anatomy, so just go through it. And this is the artery supply of this colon. And do you know which kind of artery? This one, SMV, is called superior mesenteric artery. And what this one is called, so this is two major blood supply. And from this SMA, there's three different branches. One is ileocholic artery. This is the main branch. And this the right colic artery, it is found absent in 2% to 18% patients. So some patients you cannot find this artery. And this is the middle colic artery. And the middle colic artery have two branches. One is to the left, another to the right. So these three branches is from SMA. Then from inferior mesenteric artery, there's the first one is left colic artery, is here, and there's several sigmoid artery to supply the blood supply from sigmoid colon. And here, this is the superior rectal artery. There's several different names. In Western countries, maybe it's found the superior hemorrhoid artery. So in Chinese textbook, it's usually called superior rectal artery to supply the upper part of rectum. And also there's some other blood supplies. Just go through it. Okay. So the venous drainage is mirror the artery blood supply. So we have the name of the artery, the similar name of this venous drainage name. So most of the venous drainage is going to portal vein. So the right and the proximal transverse colon, first to the superior mesenteric vein, then to the portal vein. But the anal canal, the very distal part of the alimentary tract. The anal canal is going to the inferior vena cava. So the bidirectional venous drainage of the anal canal account for differences in pattern of metastasis from tumor arising in this area. So the tumor in this area maybe have a different way to metastasis. This is the vena. So most part to the portal vein, some to the inferior vena cava, then to the lung, etc. Okay. And this is a little bit complicated, I think. So this is nerves. What is called rectum? Yeah, this rectum. So rectum is a special part of this area because a very important nerve which will cause the ejaculation and bladder function. So this nerve is called hypogastric nerve. If during the operation, if you injure this nerve, it will cause sympathetic dysfunction. So it will cause retrograde ejaculation. So it's very important in male patients. So, and also the bladder dysfunction. And if you injure this nerve nearby, it's called rectal plexus, pelvic plexus. This plexus we have the two different kind of nerves. One is parasympathetic, the other is sympathetic. There's two kind of nerves. If injury of this kind of nerves, it will cause the impotence and atonic bladder. So during operation, we do more attention, especially to these nerves. It's better to preserve these nerves. So later I will explain in detail about this. This is called TME. It's a method for how to preserve these nerves. Okay. This is different layer of colon mucosa. So this is the wall. So first the mucosa, submucosa, muscularis proprius, and this selosa. 4 different layers. If the tumor located in this area, in the mucosa, it is called T1. So in the next section about the tumor, is it the cancer, we will talk about the T1, T2, T3. It depends which layer the tumor invade. So if it is in this area, it's T1. From the muscular properties, maybe T2. And if the tumors from here to here, maybe T3, and invaded outside the selosa, it's called T4. So we will just explain it later. Okay, so then go to the physiology of the colon, which I just symbolize it. So the cycling of nutrition, absorption, so some sodium, water, and the bile acid can be absorbed. Because the material in the ileum area is fluid, and after the form the fecus, it dry. So a lot of water, sodium, and the bioducts can be absorbed, and also secretions. So the potassium, chloride, hydrogen, and the bicarbonate. The motility also. The colon can different way to contraction. So it's the tonic attraction, mass peristalsis, etc. So this is gastrocolic reflex. So after you have the meal, the colonic will move fast. It's called gastrocolic reflex. So some patients, after they eat, they have the feeling to defecation. So this is called gastrocolic reflex. And also form of stool and defecation. And because before the operation, we usually do the bowel preparation in our country. The purpose for the bowel preparation, one is purging the feces, a lot of feces in the rectum and colon, and reducing the concentration of chronic intraluminal bacteria, a lot of bacteria. So someone said the microorganism in the colon compose up to 90% of dry weight of feces. So the most part of feces is organism, microorganism. So it's better to eliminate this microorganism before surgery, but this is controversial. In the United States, we do like we do before the operation, generally do the bowel preparation, but in some European countries, I don't know you know or not, it's called fast track surgery. In fast-track surgery, they do not do the bowel preparation. It's okay. So someone without use of preoperative purging. So there's some controversial of this. And the rectal examination, maybe the different one is endoscopic. The first inspection, so maybe near anus area there's fistulas, or maybe it's endofistula, and endocondyloma. Condyloma, do you know this one? This sexual transmitted disease, something like that. And external also ulcerations, hemorrhoids. So many things you can expect it to do. And the second part is palpation. You can use your finger digital examination. So you can feel the tenderness of the anus and the sphincter tendon. So there's two kinds of sphincters. One is external, the other is internal sphincter. The sphincter tongue, if the older patient, the tongue maybe is lower, then it will cause incontinence. So, for the female is cervix, male prostate, the rectal masses. I think maybe more than 50% of rectal masses you can reach by your finger. So the digital examination is very important in rectal examination. And also coccyx. For the for endoscopic, so it's very important to diagnosis. So there's two different kinds of endoscopics. One is proctosigmoid scope. This is not popular in our hospital because it's relatively short and rigid, but it's simple and with low complication. It can only reach into the sigmoid, cannot go further. So mostly we use flexible colonoscopy. Flexible. You can go to that. Then we from anus we can insert this colonoscopy, go into the ileum, the end of ileum. So the whole colon and the rectum can be seen clearly on the screen. And the last part, the radiological studies. So nowadays we use the most popular CT, MRI, and ultrasound, B ultrasound. Sometimes we use belly enema, but when the patients have an obstruction or the bowel perforation, it is contraindication for bowel enema because the barium, if the barium go into the abdomen, it will cause very severe complications, even cause the patient to die. So barium enema is not so popular, but it's very useful for diagnosis. And this is a different position for examining the patient. And this one is most popular in the older patient department to examine. It's called left lateral decubitus position. So you can do the digital examination here, just go into it, look. And this position is popular in the operation room, especially the patient received the cancer operation. So it's called isotomy position. It's also used in the urinary department. And for this squatting position, you can see here, the small tail. No, this is not tail. Maybe some hemorrhoids go outside, or the rectal prolapse go outside. In this position, you can ask the patient to squeeze. Then the masses or hemorrhoid in the rectum maybe go out. You can see clearly. So squeezing position sometimes we use, and this niche chest position, I never use this one. Okay. And this the digital rectal examination I just mentioned is very important in the examination of rectal disease. So the posterior wall of rectum, this is sacrum and the coccyx. And for the male anterior, this is the prostate. For the female anterior wall is the ureter. So the finger is about, I think, 6 to 7 centimeters length. So you can go reach this area from the anus to the proximal part, 6 to 7 centimeters. If any muscles inside, you can touch by your finger. Also, the tenderness of this sphincter area, the tongue of the sphincter. So it's very important for this examination. It's called digital rectal examination. So this is the barrier enema equipment. Is very common in the radiologist department. So the complication rate with this procedure is very low. The rate of perforation is 1 in 25,000 examinations. But if you do the colonoscopic examination, the perforation or the hemorrhoid rate is relatively high. But the sensitivity is not so good. It's only 40% to highest is 90%. 90% is okay, but not as much, not as high as 90%. The sensitivity of double contrast barrier enema, which called double contrast. So first we use barrier, and another thing is air. The column will dilate it. So this equipment, barrier enema. So this pictures show you how do the barrier enema. So the barrier liquid is instilled into the large insetting through the anus. Then do the radiological view, this barrier. If there's maybe some, this is a normal one. So this coloscopy, we usually use this one to examine the patient. It's the gold standard for CRC, means colorectal cancer screening. So it's very important to do the coloscopy. But the risk of complications, hemorrhage and perforation, so 0.1 to 0.3%. Is relatively higher than this barrier enema. But its benefit is also allows for mucosa biopsy through uses flexible scoping. If you see any lesions, you can do the biopsy. It's very important for the tumor diagnosis. So also can do the polypectomy. If the polyps inside the lumen, you can do through the polypectomy through the scope. Also, accurate localization and fusion, accurate localization. Nowadays, we do a lot of laparoscopic colorectal surgery. But if you do the total laparoscopic surgery, you cannot touch the tumor by your finger. You only use your instrument. So if the tumor is relatively small, you can not see clearly through the screen. So it's very important to accurately localize the position of this tumor. Then you know how much balls we should remove. So also can flushing and suction, and the sensitivity of colonoscopy for the detection of polyps is greater than if the tumor is more than 1 centimeters in diameter. So greater than 95% is very high. But it's a small one, usually. It's not so high. Sometimes the tumors maybe just sit behind. You cannot see clearly just this way. Maybe at the back of the wall. So, but is the tumor more than 1 centimeter large, 95% sensitivity. Okay, so then we go to the second part, is the inflammatory bowel disease. I have mentioned there are two different kinds of disease. One is ulcerative colitis, and the second is Crohn's disease. But also 10 to 15% patient, it's called intermediate colitis. What is intermediate? Because a clear distinction cannot be made. Sometimes it's very difficult to distinct which is the UC and which is the CD. I will explain the difference of UC and the CD later. So what is inflammatory bowel disease? Is a term generally used to denote two diseases of unknown etiology. We don't know what is happening. Maybe some instinct, some causes, but not so clear. And with similar general characteristics, so bleeding per rectum, diarrhea is the most common symptoms of UC and CD. So etiology is unknown. Maybe UC, maybe something with environmental influence, inadequate fiber intake, chemical food additives, refined sugars, and coarse milks. So if the patient have this ulcerative colitis, the milk, cannot take milk, it will worse, the disease worsen. And the infection agent includes this agent, so some microorganism maybe to do with UC. Smoking, so it's better to stop smoking now. A family history of IBD, so if it maybe is hereditary disease, and also altered immunological response. So it's unknown. Maybe something related with this kind of reasons. For the Crohn's disease, maybe it's also specific infectious agent. So mycobacteria, tuberculosis, TB maybe. And defective mucosa barrier, allowing an increase in exposure to antigens. Maybe it's abnormal host response to dietary antigens. Also smoking. So stop smoking now. And taking oral contraceptives, maybe it's also. And the genetic factors, so these genes may be related with Crohn's disease. So we all know that UC and CD all have a diarrhea, hemorrhage, fecals. So what's the difference between UC and CD? So in the textbook, this is just a copy from textbook. So you see this one, CD, O, 4+, 3+. So because CD, the lesion is the whole wall, the whole layer of the wall is involved. So in the CD Crohn's disease, the gross appearance you maybe found the thickened wall, very thickened wall, and the thickened mesentery, and the selosa maybe found fat wrapping appearance, and it is segmental disease. So for ulcerative colitis, it is continuous, not segmental. So this, for the gross appearance, it can be do some differential diagnosis. But before your operation, how do you got this gross appearance? Just after the operation, you can got this gross appearance. So it's not so useful before operation to do the diagnosis, use this. And the microscopic appearance. So mostly the patient receives the
colonoscopy cannot determine this now. Whether it's ulcerative or colonoscopy.
Yeah.
Cannot determine whether it's UC or CD.
We can do this. Colonoscopy is the most useful method to diagnose, to do the differential diagnosis for the UC and the CD. But for the gross appearance, you only see the sample, the whole sample, but the colonoscopy only through the lumen. So it's a very important method is use colonoscopy to diagnose UC or CD. So we just talk about this one.
What is 4 plus, 3 plus? What does this number mean?
If more plus, so more incidence to the rate, so more happening of this one. So 0, no. Understand? Okay. So the microscope appearance. Usually the patient receives the colonoscopy examination, then we do the biopsy if we find the lesion. So microscopic appearance for the Crohn's disease, granulomas. Several diseases have granulomas. We have no TB, tuberculosis is granuloma. And this Crohn's disease, if you found granuloma, it should be Crohn's disease. And the lymphoid aggregate, so this is also Crohn's disease, transmural. Because I have mentioned that the UC is very only the mucosa and the submucosa was involved, but for the Crohn's disease, the whole layer. So it's transmural. And the clinical features. So before we do any examinations, only the clinical manifestations, there are also some hint to distinguish these two different diseases. So one is anal disease, perianal disease, anal fistula. If there are any fistula present, it should be Crohn's disease. It's rare in ulcerative colitis. Also the small bowel disease, Crohn's disease, because the Crohn's disease is a pine gastrointestinal disease. The whole gastrointestinal lumen maybe will involve it. So the small bowel disease only present in Crohn's disease. Bleeding, diarrhea, almost I think the 1 plus, 3 plus, I think no difference. And obstructive symptoms more often in CD, but sometimes in the ulcerative colitis also you can see obstructive symptoms. It's not so common, but you can see. So it's not so important. Okay.
There's a lot of difference. So you can easily then differentiate between these two diseases.
A lot, yeah, a lot.
A lot of difference. So you can easily differentiate them.
Not so easily, because sometimes most patients have no anal fistula. Most, if the patient have anal fistula, you can see maybe this is Crohn's disease. But most of the Crohn's disease, the patients they have no anal disease, so no use for this one for diagnosis. You see, also small bowel disease. Not all of these Crohn's disease patients have small bowel disease. Also, we have so many things to distinguish this CD or UC, but in one patient, not all things will happen. So this is colonoscopic features. UC and CD distribution. One is discontinuous, so it's segmental. And UC is continuous, this continuous lesion. And also for this deeper longitudinal ulcers and the cobblestone, only seen in CD. And this is because also the CD is, the whole layer is involved, so it will maybe called very deep longitudinal ulcers. So I will show you the pictures, many of the pictures of the colonic features of UC and CD. Now, shoulder polyps, you all can see UC or CD.